Gastler. She is one of our lovely advisors at Tabu, and she founded Mountain to Sea PP in 2016, which is an LA-based physical therapy practice specializing in orthopedic and pelvic health physical therapy. She believes that the body cannot be treated holistically without considering the pelvic floor, regardless of age or gender. And she is striving to normalize conversations and education regarding pelvic health issues, including pain with sex, incontinence, athletic performance, and more. It is such a pleasure to have her here today to talk to us about all things bladder. Dr. Heidi, take it away.
I'm back again. And if you guys, anyone was here in the last talk, we're kind of building on this topic. And there's a lot of requests after the last talk to talk about things involving bladder. And so tonight's kind of topic is to help to give you kind of an overview of bladder related issues that we deal with routinely in pelvic floor physical therapy, to kind of give you a better idea of when to identify that you have an issue, kind of give you an idea of treatments that are available currently. And so you're kind of more empowered to make your own decisions and to get medical assistance. Something to know is that we had a few other questions come in about other questions after the first talk, and we'll kind of preview that at the end. But if you had questions related to the previous talk, we're not going to probably get to those tonight, but we will talk to you about kind of what would be upcoming in the series. So just don't worry, we're not ignoring those. We just probably won't get to them tonight because we have a lot to talk about. We're going to talk about kind of the bladder's relationship with the pelvic floor, stress incontinence, urge incontinence, overactive bladder, and interstitial cystitis, which is known as IC, or also as painful bladder syndrome. Those are kind of one and the same. So we're going to talk about a lot of different topics tonight, and realize that tonight I'm not trying to constitute this as medical advice, but more to give you an idea of what treatment's available, what questions to ask, when you might need to know, to go in for help. And so we're not going to be going over specific programs tonight of what to do if you have these issues, because you would need to seek a medical provider in your area or seek a consultation with a pelvic floor physical therapist like myself, whether it's in person or virtually, to really get a program that's specific to you and your problems. So that being said, with bladder related issues, one of the things I want to highlight here is the profound effects that bladder related issues have on sexual function, social life, and quality of life for people. These are really big problems. First thing to know is that urinary incontinence is really underdiagnosed and undertreated. 1 in 3 women will experience incontinence of some sort in their lifetime. This affects 200 million people worldwide. It's a really widespread problem, and it's something that increases with an age factor with risk. So in postmenopausal women, which is kind of the group we're speaking with tonight, 44 to 57% of women who are polled in studies related to this, usually by gynecologists, urogynecologists, say that they've experienced or are experiencing some sort of incontinence. So if you are in that group, just know you're not alone. It's a very, very common problem to have, and it's one of the most prevalent reasons that we see people in physical therapy. But it is also very treatable, and this is something that's important to know, because incontinence is one of the most common reasons that people end up in assisted living, nursing homes, skilled nursing facilities, and the like, is that they get older. And with that being said, about 75% of women who are in skilled nursing facilities or nursing homes say that they are there because they're incontinent, and that's the main driver for them going into an assisted living type of a situation. Incontinence leads to things like social isolation, lifestyle restrictions. Maybe you can't travel for as long of distances as you could. Work-related issues where people might feel like they need to stop working, or maybe can't work like they used to because they need to constantly be able to reach a toilet. Sleep quality reduction, that can also lead to falls risk in the middle of the night. And so we see people who have a lot of fractures in the middle of the night who come in with a hip replacement, or they have some sort of broken bone because they fell in the middle of the night because of incontinence. We see a reduction in confidence. We see reduction in sexual functioning and health, mostly because people have a fear of leakage during sexual intercourse. They feel like, I'm going to have leaking during sexual intercourse, I don't want to have it. So you see a loss of desire, you see a loss of that functioning with people. It's often attributed as a coinciding factor with pain with intercourse or vaginal dryness, because these things are all kind of tied together, but a lot of times we report them as coexisting symptoms. And then there's a cost factor. people don't understand like how expensive this problem is. And so they kind of are weighing the kind of cost benefits of going in for medical care. And medical care can be costly. I mean, we have co-insurances and co-payments and things, but so are pads, laundry, protective garments, et cetera. Like that is a massive cost for people worldwide. And that's a really prohibitive thing for a lot of people. So that being said, what's the relationship between the pelvic floor and the bladder? So as we kind of talked about last time, here's our pelvis, okay? And inside of this, we've got our pelvic floor. And inside this pelvic ring, our bladder is inside of here. So the bladder is cradled by these pelvic floor muscles, okay? Superficial pelvic floor muscles, like out here, we can see here's our urethra right here, okay? These superficial pelvic floor muscles that you're seeing on the outside here, these are what are surrounding our sphincters and are helping us with control. Now, this is all skeletal muscle, meaning that we have physical control over it. Like we can make a decision to contract or relax these muscles versus smooth muscle, which is like what's made of like the bladder lining or the intestines, which we don't have automatic control over. That's something that's part of our body's natural function, but we can't control it the way we can skeletal muscles. But we need to be able to control these muscles to control leakage and also to be able to go to the bathroom completely. And we'll talk about that more here in a couple of minutes. So with that, we need to be able to have adequate thickness of these muscles. We need to have adequate coordination of the muscles. We have to have adequate control over the muscles in order to close our holes. Our bladder that's inside of here has what's called the bladder neck. And the muscles of the pelvic floor help to basically position the bladder neck. And if that bladder neck isn't supported, that can lead to leakage because the muscles aren't strong enough to hold it in place when we have an increase in what's called intra-abdominal pressure. And if you remember from last talk, we talked about how this is all our core here. So pelvic floor is the bottom of our core, abdomen's the front, diaphragm is the bottom. So when we have an increase in pressure through here, when we cough, sneeze, laugh, lift, etc., have intercourse, you have this increase in pressure. And if that bladder neck isn't supported properly, that can lead to a leakage. So we need to learn proper control of the mechanics of this inner abdominal area and inner abdominal pressure. And then more externally, those superficial muscles I was showing you, if they don't have enough kind of strength, thickness to them, they provide basically a backstop for the urethra. And if that doesn't happen, and we were talking about kind of vaginal atrophy last time too, if we have that atrophy and like loss of urethral kind of backbone, then that can lead to incontinence as well. Motor control and coordination are super important as well as like the thickness and strength of the muscle. So you can have strong, thick muscles, but if you don't have motor control and you don't have coordination, if they're insufficient, again, the bladder neck can get malaligned if you have an increase in the inner abdominal pressure, and that can cause leakage. And again, if you don't have the control and the coordination to close your holes, like if you have an increase in inner abdominal pressure, the urethra and the sphincters won't close properly, and that can cause leakage from like that external muscle layer. A lot of people have heard the term slow twitch and fast twitch muscles. And if you aren't familiar with that, fast twitch muscles are muscles that contract quickly. So it's like a real quick, snappy response. Your slow twitch are more your endurance muscles, okay? In our pelvic floor, if we're talking about like the pelvic floor as a totality, about 30% of our muscles are fast twitch, which are closing quickly, and 70% are slow twitch, meaning that they're more of like the long endurance holding. And the reason why I bring that up and it's important is that when we talk about pelvic floor muscle training, we have to make sure that we're training both sides of those muscles and not just training only the fast twitch or only the slow twitch. We need both because we need that strength, the coordination, the motor control, etc. So a lot of people call in and we get referrals all the time and people are like, I don't know if you guys are the right people for us to start with. Oh shoot, sorry, dumping my water. Always special. They don't know if we're the right people to start with, and sometimes we are and sometimes we aren't. Bladder-related issues truly can be a multidisciplinary approach. It can be pelvic floor physical therapists, urogynecologists, gynecologists, urologists. It can involve psychiatry or psychology, and we'll talk about that more later. But really, it can involve a lot of different people. It might involve a dietitian, other types of medical doctors, if there's like an oncology issue or something else going on too. So if people are unclear, and if they're kind of telling me symptoms that we're not really sure if this incontinence or this bladder problem is something we can treat. And if we are concerned that there might be, you know, an infection, like a UTI or a kidney infection, bladder infection, if we're concerned that might be a cancer related issue, if we're concerned that there might be like fibroids, cysts, endometriosis, something else that's tying in, we may say that we're not the first place to start. So you may need to go see a doctor, and we can help make referrals for you for that, for a pelvic exam from a physician, urine cytology, which is looking for like bacterial culturing and looking to see if there's some sort of an infection, a cystoscopy, which is kind of a nasty test, but they put like a tiny little camera up the urethra to look at the inside of the bladder lining to make sure that there isn't something like damaging the bladder lining where you have some sort of a problem with that. There's a test called a hydrodistension, or they also call it urodynamics, where they actually are looking at filling the bladder and what happens to the bladder fill and how much can you fill it. Are you able to void completely? Sometimes it goes along with ultrasounds to look at kidney and bladder function. And sometimes we're also looking at a biopsy, where they're doing a biopsy of the bladder or something else, making sure that there isn't a cancer or some sort of other mass. So if, and not everyone has to go through any of those things, but if someone comes in and their symptoms are smelling like infection, cancer, something else that we don't deal with, we may refer out for that first. If those things are not pertinent, then people can start with pelvic floor PT, and we may start, we might have to do co-treatment with those other types of physicians, and in many cases we do, but we don't necessarily have to start with this test, but just know that those are things to know that exist. And so if you're kind of thinking that is a concern of mine, that might be your route of starting versus coming to pelvic floor PT to start. So let's kind of start talking about the specific different types of bladder issues that we see most frequently. Stress incontinence is one of the biggest. Okay, stress incontinence is when you have urine in your bladder, you have an increase in this intra-abdominal pressure we were talking about, your sphincters don't close properly, or that bladder neck descends, okay, and then you have leakage. So, and again, intra-abdominal pressure increases when we cough, sneeze, laugh, jump, lift something. And oftentimes this is associated with pelvic floor muscle weakness, okay, or atrophy. It can also be a loss of motor coordination or control issue, which is totally separate from weakness, okay? And we need to make sure that we're addressing all of those things, okay? Stress incontinence, the treatments for this involves teaching people how to contract their pelvic floor muscles. And this is important that we also aren't doing just like laying down treatment, like where we're teaching people how to do Kegels, like laying, but we also need to teach people how to functionally use their pelvic floor muscles and create contractions with an increasing intra-abdominal pressure. So say we teach people how to engage the pelvic floor muscles before they cough, sneeze, or laugh, or as they're changing position, as they're lifting, how do I contract that? And that involves both that fast twitch muscle, as meaning where we have to tighten things quickly, and also long endurance holds. Like if I'm carrying groceries from my car up my steps to my house, I have to contract, and then I need to hold so that this intra-abdominal pressure increase as we're carrying an object. We can maintain that the whole time, and we don't make it halfway to the house and then leak. Okay, so we need to have both like an understanding of how to contract those muscles, as well as an understanding of how to functionally use them. We also need to be able to relax our pelvic floor muscles. And if you were here last time, I talked a lot about how oftentimes people learn how to do Kegels, but they learn how to contract the muscle, but they don't learn how to relax it, okay? Why do we need to learn how to relax the pelvic floor? Like, why is this important, okay? If you can't relax the pelvic floor fully, we can't get full bladder emptying. And if you can't get full bladder emptying, and we always have urine sitting up in there, then we're more likely to have an accident because we're not fully voiding. It's also important because we have found that when people have an increase in tone of their muscles and things are more kind of amped up, we tend to have a more leaking. So we need people to be able to relax, detone, kind of de-stress those muscles so that we fully can have full function of the musculature. Some of this pelvic floor physical therapy for this looks like progressive strengthening, training again of both those fast and slow twitch muscles. We might be using biofeedback. We might be using at-home devices. I'm a really big fan of a couple of devices for at home that are like an app-based biofeedback device, because when you're using those, people can really tell what they're doing with the muscles. It gives you something to squeeze on, so it gives you something for proprioception of being able to really tell if you're squeezing. and also that you're relaxing. And you can use these devices for training the different phases of those muscles too, the fast, the slow, the endurance holds, the power. And there's a number of different devices. I'm happy if people want references for, I can certainly give you some suggestions for those. But I find that patients do really well with those in terms of compliance because they actually enjoy using them. They see progress and they find that like it's something that they'll actually use as part of their home program because they can actually see measurable progress versus someone who's just like trying to do a bunch of Kegels and they don't really even know if they're doing it right or not.
Dr. Heidi, do you have your top 2 favorites that you could tell us?
Yeah, so my top favorite is called the Kegol. It's K-GOAL. That's my top favorite. And the reason I like that is that it has basically a balloon that you can open up into the vagina. So it gives you more of a filling of space. And also you can set it that when you when you contract onto it, it actually gives you a vibration. So you know that you contracted properly. So you're getting that tactile feedback versus just squeezing and not being really sure. So that's my top favorite. There's another one called the LV that I like as well. I find that the app is really easy to use on the LV. The problem I find with the LV for a lot of my patients is that it doesn't give them enough tactile feedback. It's really small, so it's easy to insert and the app's really easy to use. But a lot of times people feel like it gets lost in their vagina and they can't really feel it. And so if they can't really feel it, then they find that it's hard to squeeze onto. And so I haven't been recommending that one as much. But if somebody has vaginal pain associated and the Kegel might be kind of hard to insert, the LV is a really good option if we're dealing with a pain issue. Or if somebody has a lot of prolapse into the vaginal area, sometimes the Kegel is hard to get in and the LV is easier to get in.
Okay.
So those are the 2 that are my primary favorites. When we're talking about this pelvic floor strengthening, this is where vaginal weights and cones can start coming into play for teaching endurance. And the thing that's important to know about vaginal weights and cones is that if you can't relax your pelvic floor muscles, you shouldn't be using vaginal weights or cones because you need to be able to get that contraction and relaxation. We don't want you just walking around contracted all the time. So with that being said, I wouldn't, if someone can't demonstrate that they have that ability to have like that on and off switch, I don't let them, or I don't like advise them to use vaginal weights or cones as part of a home exercise program. Because with those, you're effectively holding that weight up in your vagina and walking around with it in or sitting with it in and not letting it fall out. So you need to be able to get that contract and relax first. But sometimes the vaginal weights and cones can be appropriate at this point if you're trying to teach somebody more like long endurance holding type of things. Another part of pelvic floor physical therapy that has nothing to do with Kegels at all is correction of like what we call like bad habits, okay? And a lot of these, as I go through them, people will probably identify with, okay? So one of them that's really common is just in case peeing, okay? Like, oh God, I've got to go. I'm just going to pee in case of whatever, okay? This actually can teach a bad habit because we may be voiding and teaching our bladder that there's this signal to void before we need to. And we might start having issues where that's relating to like a feeling of like a loss of continence later on. So we're basically teaching our bladder to incorrectly interpret signals. Semi-squatting. So when we hover over the pot, we don't let our pelvic floor relax because our muscles are all holding us up. You need to sit down to pee and poop, okay? If you're at McDonald's or if you're at Starbucks or in the airport, use a seat cover, but you need to sit, okay? The hovering is never advised for this type of issue because you aren't able to fully relax. So again, that leads to not having incomplete elimination, having like maybe like a stop-start pee. Sometimes people can't pee at all. You need to actually sit down and relax to go to the bathroom. A lot of people have heard from their doctors that they should Kegel and stop their urine mid-flow. So it's like, I'll pee a little bit and then stop it. Pee a little bit and stop it. And again, this can kind of teach our body bad neurological habits. We don't advise that. And then the last thing is straining. So like if you're trying to pee really fast because you're trying to get off the toilet and you're pushing down to strain, we don't like that either because now instead of just letting the pelvic floor muscles relax, we're actually pushing them into distension. And this is one of the issues too. If somebody has prolapse and they have prolapsing tissues and now they're straining and their pelvic floor is hanging down into a bowl, this can actually make prolapse significantly worse as well. So it has carryover to other types of pelvic floor issues. Another thing that we advise people in is dietary modifications. Okay, now some of these dietary modifications are things that we can make, we can work with people on. Sometimes we actually need to partner with a dietitian. So things that we know can cause more incontinence issues are acidic foods and beverages like coffee, soda, alcohol, spicy or acidic foods, so tomato, spicy foods, chocolate, caffeinated beverage, citrus, MSG. We know that these are all bladder irritants. Okay, same with carbonated beverages. So like I personally love sparkling water. That being said, sparkling water can, for some people, cause bladder irritation, and it can cause more feeling of need to pee, and it can cause more feelings of bladder irritation and incontinence. So we work with people on what are called bladder diaries. And a bladder diary is when we're literally looking to see how many times a day people are going. We ask people oftentimes to measure the amount of urine that they're producing. There are these little urine hats that you can put in your toilet and actually measure how much you're going to the bathroom. So we can see, like, is this just like a little bit? And so we're peeing all the time, kind of those just in case pees, or are these actual full urinations every time? And so we have people do a bladder diary where we're checking for the timing of voids, how much they're going for, like how much like the actual volume is. Are they defecating? Because that makes a difference. What foods they're consuming. Because if we start seeing patterns, then these are things that we can make modifications and like lifestyle habit changes. And oftentimes these really help people to have less of these incontinence episodes. Hydration management is also really important. And this always throws a lot of people off because people think that if they drink more water, they're going to have to pee more often. In reality, if we are dehydrated, our bladder and like the environment inside of our bladder actually becomes more acidic. And that increased acidity, just like with the foods we're already talking about, can cause to more bladder irritation and more leakage. So the current standard for like how much to drink, because this is always a question, is whatever your body weight is in pounds. The current standard is that you should be trying to drink half of that in ounces of water per day. So for example, I weigh about 150 pounds. So I try to drink about 75 ounces of fluid a day, which though is like a little bit like, so like 2 1/3 liter, which for a lot of people, they're drinking like 2 cups of water a day. So 2 cups to like 2 liters is like a massive gap, right? And they've only been drinking 2 cups because they've been kind of holding back on how many fluids they drink because they don't want to have accidents, but their body is super, super dehydrated and they're having problems with acidity, and this can actually lead to our problems. So we don't overnight have someone go from like 2 glasses to 2 liters. This is something we can help people to increase at a steady rate over time, and making sure that people are kind of hydrating and increasing their hydration at like an appropriate rate and not increasing their accidents, or especially like the nighttime accidents. Weight management is also an issue. And this is where we might have to have a registered dietitian come in, maybe some sort of other medical doctor. And everyone always wants to know, like, why does my weight matter? And the problem is if we have increased abdominal weight, it compresses down on the bladder and compresses everything on the pelvic floor and can cause more pelvic floor distension or more pelvic floor tension, trying to hold all of that up all the time. So when people have weight management issues, that can actually increase to urinary leakage as well, in all forms of incontinence. Another thing is diabetes management. How does diabetes affect urination? Okay, if we have poorly controlled diabetes, it can cause nerve damage. Nerve damage, and if we're having poor signals to the bladder, poor signals to our urinary system, and poor signals from our brain to our bladder, that can actually change our ability to control and make us feel like our voiding is off or timed differently. So diabetes, and having your diabetes well managed, can really help to improve incontinence episodes. The other thing is, if diabetes isn't well managed, is that your body can't eliminate glucose fast enough. So the only way for it to eliminate glucose is actually to urinate more. So you might find that you're having to go to the bathroom more. And that's why a lot of times people are asked, are you going to the bathroom a lot? Like, are you thirstier? It's because your body's trying to eliminate glucose in some way, shape, or form. Then smoking cessation. People want to know, like, why does smoking, again, affect my bladder? So again, smoking, and we know that smoking cigarettes can affect our bladder lining because it can, again, be like a bladder irritant. Also, if people are coughing a lot from any type of smoking, whether it's vaping, marijuana, cigarettes, e-cigarettes, whatever, if you're coughing, again, we're getting this increased abdominal pressure, and then you can have increased in leaking. And then, of course, increased cancer risk. We might have sort of tumor or something that's associated with smoking in the bladder. Lastly, with like talking about this part of incontinence, and you'll see here that there's a lot of carryover from what I'm talking about now into our next, our next conversations as well. So those will go a little faster, is stress management. So if people are highly stressed and our muscles are at a higher tone, we tend to have more urinary leakage, okay? So things that we can do to help with that are learning meditation techniques, learning relaxation techniques. Sometimes we need psychology to be involved for coping skills, because sometimes, again, people have this feeling like they gotta go, and it's part of an anxiety response, especially when we're leaving the house. Maybe we're going to do something and we have this subconscious anxiety that, oh God, I don't know when I'm gonna get to go to the bathroom again. So we avoid, and we have that just in case pee, and it starts perpetuating this cycle, okay? Again, that increase in tone too can cause incomplete voiding. So you might think you went to the bathroom all the way, but then you have to go again pretty soon. Or maybe you have a stress incontinence issue because you still have urine in the bladder because you didn't void all the way. Okay. You can also see things with urinary, like with basically urinary retention that look like having like hesitation, a slow stream, spraying, where like the pee just goes every which way. It doesn't just go straight down. Urinary retention, and all of these things can cause feelings of urgency, but they can also cause that stress urinary incontinence because we haven't completely voided in our bladder. Okay.
Dr. Heidi, we have a question related
Yeah.
specifically to this, is why does anxiety increase the need to urinate?
So there is a feedback loop, which is super complex between the brain and the bowels. And if our stress level is higher, it gives us this feeling like that we need to eliminate or evacuate our body. So if our stress levels are higher, then that will actually give us that feedback loop saying that we need to completely void, number one. And number two, it can cause, again, like where I was talking about this feeling of retention. So if we're anxious or like holding and guarding our muscles, if we're not fully evacuating our body and we're not letting everything come out when we actually do go to the bathroom, and we have this retention, you don't know that your bladder isn't, has something still in it. And then you cough, sneeze, something that causes that increased abdominal pressure and stress. And then we get peeing because we didn't completely void, even though we think we did. Does that make sense?
Yes, thank you.
Okay. So last part of this, and then we're going to move into urge incontinence, and you'll see there's a ton of overlap here. Okay. So again, stress incontinence is when we still have urine in the bladder, and then we have this increase in pressure, and then we leak. Okay. We'll go into urge incontinence, what the difference between the two here next. But the last thing to know, because these things again carry over, is the medical side. So oftentimes I'll work with like a urogynecologist, and we may have somebody who's fit with a pessary or trying to get fit with a pessary. In a pessary, I like to think of it as like an internal like ankle brace for your vagina. It basically is helping to hold your urethra in the right position and give it, again, that like backstop for the urethra to keep it in the right position, so that it's giving the muscles support from the inside if they're a little too weak, to allow us to have that urethra in the right place to have less leakage. Okay. That being said, the pessary can go along with physical therapy because the pessary can help support symptoms and help us to have symptom control as we work on motor coordination, control, strengthening, et cetera, in physical therapy. And I find that a lot of times the two things go really well hand in hand. We also have a lot of patients who come in who can't get a pessary to stay in because they have so little muscle tone. So if patients can come in to physical therapy, get more muscle tone, oftentimes they can go back to the urogynecologist, get fit with a pessary, and it'll actually stay put, whereas they may not have been able to do that before.
We had a question about this specifically also. Can you use things like the Kegel or LV if you have a pessary?
Yes, you can.
Okay.
So those two things can definitely be used simultaneously. Some things that are a little bit larger, you may not be able to use the same time, but like with a pessary, I haven't had anybody have problems.
Wonderful, thank you.
So there's another device that's made by Poise, which like makes all the pads and stuff, that's called the Impreza. I honestly don't know how big the Impreza is because I've never actually seen one in person. All my patients that have pessaries go and get fit by a urogynecologist, but Poise is now making an over-the-counter device called an Impreza. This does the kind of a similar thing to the pessary. Pessaries are kind of like a single-use thing. Like, think like you go and get a retainer made, right? It's made for you, fit for you. You can use it over and over. The Impreza is a single-time use device that basically is inserted like a tampon and then stays up inside. And I don't know the size of it, so I'm not sure if you could use a Kegel and an Impreza at the same time, but it does give people kind of a more cost-effective over-the-counter option. And you could certainly try this Impreza device, and it's IMPRESSA. So like, I'm impressed, okay, is what that is. And so that's, again, like an ankle brace for your vagina, but it's an over-the-counter option if you wanted to try something like that. But on both of them, the fit is extremely important. So if you go try to use Impreza, or you try to use a pessary and it doesn't work for you, it may be that it's just not fit properly. So don't give up on it right away. Just realize that the fit is super important. And if it doesn't work the first time, try again and see if it works. Again, on the medical side, if we've got somebody who's really overweight, they may need medical intervention for helping with weight reduction. If we have somebody who has stress incontinence issues and nothing else has worked, okay? And these are this is like last case scenario, like PT hasn't worked, other things haven't worked. And we'll talk about some of the other medical techniques that can be used here in a minute. But last case scenario is like a surgical bladder sling. And so there's the mesh, which I try really hard not to have people use, but it's still being used. And then there's also what's called a fascial sling, where they're actually using your body's own tissue to create like a sling to help to hold the bladder into the correct position. That can be useful if it's kind of like a last case scenario. The reason I don't like the mesh is that there's a lot of people who have side effects to the mesh. And so we may see like other pelvic pain issues related to like the actual mesh implantation. And we might see those down the road. So like, I don't love that. And I kind of try to guide people around away from it. And the FDA has actually banned mesh from a number of different procedures, but not all of them. So it's always a good thing to discuss with your medical provider of, is there another option for me besides mesh? Could I do like a fascial sling where I'm using my own body's tissues to hold this up? Because we see far and fewer long-term side effects when we're doing like a fascial sling. Urethral bulking is also a thing. So we were talking about the urethra not having enough of a backbone. So they can actually do things like collagen injections into the urethra. Now it doesn't like a one-stop shop thing. Like you have to usually have them redone every kind of like 6 to 9 months. But sometimes people will feel that urethral bulking procedures and injections can help with having a reduction in stress incontinence, because it gives them the ability to close that urethra better and have those external sphincters close better. And again, these things can be done absolutely in conjunction with physical therapy. And I think that they work well together, because we see people have better kind of overall results with kind of a multimodal treatment versus just one or the other.
We had a quick question come in is that the same or similar as Botox injections?
No. We will go into that. So urethral bulking is you're actually trying to increase the bulk, versus Botox is just trying to relax something. So that actually comes into our urge incontinence and overactive bladder, which is where we're going next. So stress incontinence is, again, too much. We got urine in the bladder of any sort. Inner abdominal pressure increases, pushes it out, we leak. Okay, with coughing, sneezing, laughing, lifting, etc. Okay, overactive bladder and urgency incontinence is where we're going to talk about next. And I'm going to tell you kind of what the difference is between the two, but then we're going to talk about the treatments as a whole, because I think that the treatments for the two conditions, regardless of the original diagnosis, are very, very similar. So overactive bladder is a strong and sudden urge to urinate that you just literally can't ignore. It's like, I've got to pee right now. It produces anxiety that you're going to leak if you don't get to the bathroom right away. Even if you don't leak, it's that feeling like, I'm going to if I don't get there. Okay. This is your nerves telling you that you're full, your bladder's full, but you may not actually be full. Okay. So remember, I was talking about before that sometimes our nerves will give us an incorrect signal. This is what that is sometimes the bladder is only like a quarter full or half full, but it's telling you that it's abundantly full and you've got to go right now, but you may not be. Okay. So really the bladder nerves are controlling your brain versus the other way around. Okay. There's a number of risk factors that can can lead to this. Neurological disorders can lead to this, to either the brain or spinal cord. So people can have things like strokes, spinal cord injuries, concussions can lead to things like this, strokes, MS, just like you can go down the list. And this can change a transmission of signals from the brain to the bladder. Okay. Hormonal changes can cause this as well, where our hormones can kind of start telling our bladders that they're having a mixed signal. Pelvic floor weakness or spasms can cause this. Okay. Having a UTI can certainly cause this, or a bladder infection, as well as medication side effects. Sometimes people will be on a new medication and they start having this feeling like they need to go all the time, and it actually ends up being a medication side effect. So if someone has this condition, I always ask, like, did you change medications recently? And we'll like look and see like the whole medication side effect list if this is a medication side effect, because sometimes it can be as simple as that, is that they're having a bad reaction to a medication they're on. So conversely, urge or urgency incontinence is that you have to go now and then you leak. Okay, so overactive bladder is that you have that feeling but you may not leak. Urge incontinence is that you actually do and oftentimes can't make to the bathroom. Now, the two can be really tied hand in hand, but they are kind of separate diagnoses. So again, talking about the pelvic floor PT, a lot of these things are very much what we already talked about. Bladder diaries, how often, how much, what foods people are having, is there constipation? The reason why constipation is important is if you have like a lot of fecal matter up in the the rectum and the colon and in the intestines, and that can actually push into the bladder, and it can make you feel like you need to go more often. Okay. We also do bladder training with this, and this is a really important component of this, is that with stress incontinence, people are doing an activity and then they leak. With urge incontinence, people are just leaking or feeling like they got to go all the time. The same thing with overactive bladder. And again, sometimes it's the bladder running the show versus the brain running the show. So we start working with people on bladder training. So with that, we do timed voiding. So instead of you just go whenever you feel like you need to go, we start trying to reteach the bladder the correct signals of like actually being full, by having people start with, instead of going whenever they need to go, trying to go at like, say, 60-minute intervals. And when that becomes easier to just go to the bathroom once an hour, then we start increasing it by maybe 15 to 30 minutes. And then we have them go to like an hour 15, hour and a half in between voids, and increasing that as we go along. We then try to work up to like 2 to 3 hours in between voids. And so that people have more freedom, that they're not having to go to the bathroom like every 5-10 minutes. It's like they've got more freedom to work, travel, live, do things like that. We also, again, work with people on healthy fluid intake. We start working on kind of like normalizing, like avoiding frequency, improving bladder habits. Again, sitting down on the toilet, not hovering, okay, having people not be like pushing to go to the bathroom, kind of those same things we talked about before. This is kind of like working on establishing central control. And when I say establishing central control, I mean from the brain versus the bladder. We're trying to improve feelings of like kind of the suppression of urgency. We're trying to suppress that. We're trying to improve bladder and pelvic floor muscle control, improve bladder sensation and awareness of signals, and improve activity of daily living function, meaning that you're not having to go to the bathroom all the time, so you're able to do other things. Okay.
Can I do that, Dr. Heidi? We had a question come in. What is considered normal intervals?
So normal intervals is that people are going, I wrote this down and where did I put it? Hold on 1 second. I'll tell you, because this is one of those things that like, it's kind of like a spectrum, but let me just look at my notes really quick, because I can tell you what's considered by studies to be the norm. Give me just 1 second, because they do studies on this and like what is like actually considered to be like a normal amount to go. And you have some people who say they go upwards of like 20 times a day, and this is like much, much fewer than that. Like I remember when I was in school or like doing like the class, like for work for this, I was like, really? Like I for sure go to the bathroom more than that. Okay, so what's considered normal per research is that in a 24-hour window, you're going 5 to 8 times total in a 24-hour window. Okay, which I remember thinking like, I go way more than that, but that's considered the average normal is 5 to 8 times over 24 hours. These are like 3 to 4 hour intervals in between voids is considered the normal. We start trying to get people up to like 2-hour voids, or 2-hour intervals first before we go to like 3 to 4. And what we're trying to do is we're trying to establish that people can comfortably hold it for longer and they're also having success. So we're not saying hold it for 4 hours and then you're leaking, because that doesn't really help. So we want to have people be successful as they're increasing it. After bedtime, like when you go to bed, we want to have no incidences of waking up to go to the bathroom, or maybe one. So that might be dealing with like what time, like your timing of when you drink. Like a lot of times people are trying to get to that, like, 2 liters of water a day sort of thing. And they get to right before bedtime. And I tell people this all the time. Like if you haven't drank the amount of water you're supposed to have for the rest of the day, don't go and pound a liter right before bed, because you're going to be up all night. And that's, miserable. So you want to be spacing that out over the course of the day versus just trying to pound all of that right before bed. So sometimes, timing of when we drink is important. And maybe if you go to bed at 10, you stop drinking water at like 7 or 8, and you don't drink anything for that time before you go to bed. Or maybe you just have like a sip of water to like wet your mouth, take a pill, whatever, but you're not again pounding water before you go to bed. And what's also considered normal is that people aren't having just in case pees. That's not considered to be a normal function, is that you're having to have those just in case pees we were talking about before. Some of the other things that we kind of work on with people is we work on urge suppression. So urge suppression, if you are feeling like you need to go to the bathroom, say you're like in this talk, right? And you're like, oh my gosh, I need to go to the bathroom. If we teach people how to pull the holes up and in, so we're teaching people how to do a proper Kegel, that can help this feedback loop between the brain and the bladder, saying that we have to go, by kind of interrupting that signal and almost distracting the body so that you kind of have that suppression of that urgency to go. Sometimes that can be a change of position. So if you're sitting, you go to standing, going to sitting, be crossing the legs. So your perineal body is this area that's right between your vaginal canal and your anus. This is your perineal body right here. If you actually put pressure up into the perineal body, that can actually cause an urge suppression. And that's where we get the pee-pee dance. So when we cross our legs, we're actually putting pressure on that perineal body, and that can help us with urge suppression. So like the I've got to go potty dance actually has a function with distracting us by putting pressure on the perineal body, changing positions, causing a distraction. And so with urge incontinence issues or overactive bladder, we try to get people to wait for the urge to pass before they go. So you're kind of trying to work your nervous system through that urge and work your way through that and then void, so that you're not rewarding your urge and going to the bathroom and giving into it. We're trying to like let that pass. And again, get that central control back versus your bladder controlling the show.
I have a question related to this also that I wanted to bring up about why does the urge come when you're in front of the kitchen sink or even perhaps at the gas tank? Is there a reason for that?
No, that's kind of more like a psychological phenomenon where like people hear water and they think that they need to go, or that psychological phenomenon of like, you didn't have to go to the bathroom, but now you get into the gas station there and there's a bathroom and like you have to go right now. There isn't like a physiological reason, but there can be like a psychological tie-in to that, where you have this kind of relationship in your brain between, the water or the gas pump and needing to go to the bathroom, or like being at a gas station, there being a toilet nearby. Like I find all the time that it's like, I didn't have to go, but now I'm in the house. It's like, I've got to go right now. And it's like that psychology of having it close at hand and feeling like I can no longer hold it. But those are things that you can use urge suppression techniques, like we're just talking about, to help to reduce that urge and like wait for it to pass and then go, versus sprinting to the bathroom. So, but there's no physiological. But people ask like things like that all the time. That being said, if you are having, incontinence or overactive bladder issues and you're trying to travel, like bathroom planning can be really important, because again, we're trying to increase these periods in between going to the bathroom, but we're not trying to make you go forever. So if you're driving, say, from LA to Mammoth, if you can kind of go like, okay, I'm going to try to go this much distance and there's a toilet here I can use, especially right now in COVID, where a lot of bathrooms and stuff still aren't open yet. it's really important to kind of know, like, along your route, like where there are bathrooms that are actually accessible to you, so that you can actually kind of have that bathroom planning. Or, you know, other things like throughout your day, like having that planning can be important, because again, that can reduce some of that anxiety related to travel, and it can actually help make you more successful with treating incontinence issues, because you're not having to hold it so long that you actually are too full to hold it. So again, with urge incontinence and overactive bladder, same dietary modifications, same weight management, same diabetes, same smoking cessation, same stress management. All of those across all of these conditions are important. So it doesn't matter which of these bladder issues we're talking about, all of those management things are important, and they're the same across the board. So we don't need to go through that all again, but realize those are all across the board issues with bladder problem. Now, something that's different with urge incontinence and stress incontinence is that there are a number of different medical treatments that are FDA approved for urge incontinence that have not been approved for stress incontinence, because they're more like neurologically based, where like we've lost the central control. So that being said, pharmacological for urge incontinence, topical estrogen has been approved for urge incontinence, but it hasn't been approved for stress incontinence. Antispasmodics, again, the bladder, like making sure that the bladder isn't maybe spasming, or the pelvic floor muscles aren't spasming and pushing on the bladder, have been approved. Anticholinergics, which again block neural transmissions. Beta-3 agonists, which help with relaxing of the smooth muscle. So the bladder itself is smooth muscle. So helping with smooth muscle relaxation, because we can't automatically control that muscle the way we can skeletal muscle. And this is where the Botox comes in. Okay, so Botox has been approved for urge incontinence and for overactive bladder, but not stress incontinence. And so with Botox, they're either injecting it actually into the bladder wall. So they're working on reduced spasming of the smooth muscle of the bladder. Or if you have spastic muscles in the pelvic floor that are cradling that pelvic floor, sometimes they'll do Botox around that. Now, that being said, you need to know that those muscles need to be able to contract and relax. So if you're Botoxing the entire pelvic floor, we're going to lead it to like a whole other subset of issues. So you kind of take away one issue and you lead to another. So they do this like really targeted. They're not like doing the whole thing. And also Botox wears off. So it's not something that lasts forever. Again, kind of like with the urethral bulking, it's something that you usually have to have done like anywhere from like any, you know, just like facial Botox. It's like it might last 3 months in one person, 9 months in another, but it is something that has to get redone periodically. But for a lot of people, they do find that with urge incontinence and overactive bladder that can be helpful, and it has been improved for those issues, but very separate from the urethral bulking. There's also a treatment called percutaneous tibial nerve stimulation. It's a mouthful, okay? And basically this is an electroacupuncture treatment. So your tibial nerve is down here by your tibia bone. And what they're doing is they're actually putting acupuncture nerves down here, and you're sitting in a relaxed position, and they're using this feedback loop where they're stimulating with electroacupuncture the tibial nerve, which leads up to the sacral plexus, sacrum being the tailbone and the nerves around there. That sacral plexus is what innervates your bladder and the surrounding area. So what they're doing is they're kind of doing this feedback from ground up by stimulating the tibial nerve. And it's a treatment that's done like 1 time a week or so to help with nerve modulation. And I do have several patients that are doing this in conjunction with pelvic floor physical therapy, and have found that they think it's really helpful. It's something that's done generally by your urogynecologist, but that's something to know that's out there. And a lot of people find that that's helpful. Another type of electrical stimulation, which I kind of think again is a last stop shop, is a sacral nerve neuromodulation device. It's basically a pacemaker that's implanted kind of by the tailbone, and you have wires that they put down into the sacral plexus that are implanted, and those again provide the sacral nerve plexus modulation. The problem is that sometimes people find that the device that's implanted provides discomfort around the device, so they might have some sort of like negative reaction to the implanted device. The nerves that are implanted can move, especially if people are like massaging or something around that area. And so it's not my first kind of go-to, but it is something that exists for people. And I do see them a lot with people who have neurological conditions. So I used to work with a lot of like nerve condition issues, like people who are, say for example, were like had some sort of hemiparesis or paraparesis and they had something like this implanted, or people who had really severe low back and sacral like arthritis issues. Maybe they're having like fusion surgeries and they're having something like this that was tying into that spinal condition and then was then like relating to their bladder. And so they're having this as an adjunct device, and they do exist, and just know that it exists. It's not what I would consider to be like first line of defense, but it is something that you can definitely talk to your medical provider about if nothing else is working for you. So that leads us to our last category, okay? And this is interstitial cystitis, also known as bladder pain syndrome, or IC. So this is a diagnosis of exclusion, okay? So if you have eliminated the fact that people have fibroids, cysts, endometriosis, if we've kind of said, okay, we don't have like a true stress incontinence or urge incontinence, we kind of eliminated all of the other variables. We don't have like a weight issue, a dietary issue, a stress issue, a smoking issue. Like we've eliminated everything, but you have pain somewhere from your belly button to your thighs. It can be pain anywhere, or a feeling of pressure. You also have feelings of urgency and frequency. So you've got pain, urgency, and frequency, and like everything else has been eliminated. Then you may have what's called interstitial cystitis. And this is a kind of a chronic pain management condition. And it's treated often with pelvic floor physical therapy. And this, again, has a lot of overlap with everything that we've talked about before. It's like you can improve this with, pelvic floor relaxation and contraction, working on maybe manual therapies intervaginally for relaxing tight muscles and nerve entrapments, muscular training, again, of quick muscles and long-term muscles. Sometimes we'll use electrical stimulation with these patients, either externally, like we put it like on their abdomen or like their low belly or their low back. You can also do intravaginal electrical stimulation, which if someone's having a lot of pain related to this, that may be helpful for them. Using biofeedback, whether it's internal or external electrodes, you can use that for people to help with, again, feelings of being able to contract and relax. Learning how to manage inter-abdominal pressure, keeping the bladder dilated, we've already discussed, and especially stress management. Because IC is a chronic pain condition, we see that there's a lot of tie-in, and this is with all medical conditions, but with chronic pain and nerve issue, like with neural stress and tension. So for a lot of people with IC, we do have to do co-treatment with either a psychologist or a psychiatrist, depending if we're doing medications, because there's this feedback loop between the stress and the pain, our nervous system, and the two things will interplay and kind of create this almost like a hamster wheel effect. With interstitial cystitis, Botox injections are again approved for that, for antispasmodics. There's also something called instillation treatment. And instillations are medications that are placed by a catheter up into the urethra and bladder. And these can be surface protection, anti-inflammatories, alkalizing agents. Again, we don't want to have that acidic bladder environment. Lining repair medication, numbing things like lidocaine. Those are all things that are approved for interstitial cystitis. Pessaries, again, are approved because we have that frequency and urgency of voiding in addition to the pelvic pain diagnosis. And then there's a whole host of medications that oral medications that have been approved. There's one called Almiron. The Almiron has a lot of, if you look that up on, and Google it, Almiron has a lot of kind of nasty side effects as well, but it is kind of the one FDA approved medication specifically for IC. NSAIDs are typically, are oftentimes prescribed, again, for like reduction of pain and inflammation. Tricyclic antidepressants are oftentimes, prescribed for this kind of condition, and also antihistamines, because antihistamines are thought to help to improve like the condition as well. We talked a little bit about CBD in the last talk, and this is where something that I would kind of consider for a CBD as a use for it too, if you're doing like either topical CBD, intervaginal suppository CBD, or oral CBD use. Because again, we're looking at pain reduction, anti-inflammation. So I think that that would be another thing that isn't really research based or driven, but clinically, I would say that with everything else that we use to treat interstitial cystitis, that would definitely go into that category as well. Interstitial cystitis can be flared up by a number of things. One of them is intimacy and intercourse. So with this, if we're talking about a pharmacological approach, oftentimes people will be advised to try taking an antispasmodic or pain-reducing med prior to having intercourse. Things that are non-pharmacological, making sure that we're using a good quality lubricant can be really helpful. After intercourse, you can take a sitz bath to help to reduce external inflammation, or ice pack the perineal body can be helpful for people. With travel, oftentimes that we find that this flares up icy. So if somebody's going to be like on a plane, train, automobile, whatever, sitting on a pillow can be helpful for people. The donuts may not be the best thing, because with the donut, your pelvic floor is still kind of hanging into the donut, but sitting on like a nice pillow just to help to reduce vibration can be helpful for people. Again, bathroom planning is important. For a lot of people with IC, they find that they actually need, if they're doing car travel, that they use, like they'll bring like a female urinal or like a portable potty with them, because they find that like that kind of helps to reduce the anxiety. And again, if we're reducing anxiety, and we're kind of helping to treat the psychological part of this, because it's not that you're crazy, it's just that there's a huge tie between psychological issues and pain, pain management. If the anxiety is reduced, we find that like the actual whole condition is reduced. If you're flying, maybe kind of restricting your fluids before flight can be helpful. And unfortunately, pads, it's one of those things that if you feel like, again, you're going to have anxiety about leakage, same thing as the portable potty, is like wearing like a Depends or Poise may help for reducing that overall anxiety and kind of help to tone down the entire condition. That also being said, tight clothing, so like yoga pants, tight jeans, girdles, or like some sort of like waist control, like Spanx, things like that, because this can be pelvic pain anywhere around this region. So anything that's really tight around your abdomen, around the pelvis, or under the undercarriage can also really like trigger this and make it worse. So if people are wearing tight garments, and this is the diagnosis, we oftentimes tell them to try to get rid of those for a while, especially if they're feeling flared up, because we can find that actually makes it worse versus feeling better. So that's kind of our, like the interstitial cystitis. But you can see that with all of these different conditions, there's a lot of carryover between all of them with what we do in physical therapy. And I think it's important to know that physical therapy for the pelvic floor can treat all of these conditions, and you can kind of improve all of the conditions to a high degree with just pelvic floor physical therapy. And if you kind of eliminate the pelvic floor issues related to it, then you can kind of wipe the board from that and like see what you have left and decide from like a medical perspective or a pharmacological perspective, kind of what else you need in addition to that. Because if you eliminate, say, 60% of your symptoms, you're really on kind of a better path, right? And you kind of can go like, okay, now this is much more manageable. What else do I need to do? Versus the other way where it just feels so completely overwhelming and you don't really know where to start. So I find that like all of these things, physical therapy works really well for. And it's a good place to kind of start. And you don't have to do linear treatment also. Like all of those tests I was talking about before with biopsies and, urodynamics and stuff, you can be in pelvic floor physical therapy and do those tests simultaneously so that you can be getting treatment and relief as you're doing testing at the same time and making sure that you're on the right track. Are there other questions that are coming in? I kind of keep seeing things popping up.
We have a lot of questions,
Okay.
but unfortunately we've come to the hour, but not to worry, I have recorded all of them.
Okay.
And we've peppered in answers when possible, but perhaps we can preview what we're going to talk about next time. And we'll of course follow up with answers to the questions, the recording, all of that good stuff.
Mm-hmm.
But we got so many questions about how to do a proper Kegel and prolapse care. And so that's going to be our topic for our next event. We haven't solidified a date quite yet, but we will follow up. Anything that I missed, Dr. Heidi, that I should add?
So I think that that's a good place for us to go next, because teaching people how to do proper Kegels with the contraction and relaxation, obviously on a group chat on the computer screen, I can't see what you're doing, but we can definitely talk through it and give people a much better idea of kind of what to, feel. And if when we do that talk, if people have, want to turn off their cameras, and if they have a device that they want to be using simultaneously, they can definitely do that to kind of help them along the way and kind of have the privacy too. So I'm super open to that if people want to be kind of trying it as we talk, because I think that hearing it is one thing and attempting to do it sometimes is like a whole different animal. So we can definitely talk about that. And then talking about prolapse management. Kegels are a big part of that, making sure you're doing them properly, but we can kind of tie those two topics in together. And in terms of questions from this, I can't give anyone a specific program. Okay, so if you're looking for a specific program, I can't give you that. Okay, so just know that off the bat from today's talk, is that if you're wanting me to give you a specific program, I can't do that without actually seeing you as a patient, because we need to diagnose you, making sure we're giving you the proper, diagnosis, and then develop a program for you. So like, if there's any of those questions, let's just wipe those across off the board, okay? Because I can't address them anyways. So just know that you need to actually see somebody. And I'm more than happy if people want to do, a lot of this stuff can be addressed in a fashion where we're doing a virtual visit with people. So if you don't live in LA and you want to do a virtual consultation, certainly feel free to reach out to me. Otherwise, find a pelvic floor physical therapist in your area. You can find one through hermanandwallace.com. So hermanandwallace.com, that's one of the pelvic floor physical therapy training centers, or also the APTA website, which is American Physical Therapy Association. Both of them have pelvic physical therapy finders on there. So if you're kind of going, oh man, I need this, look at that, okay? And see if you can find somebody in your area, because if you can, that would be a really good place to start for any of these conditions. So,
Thank you so much
today. I told you this was a long one. I'm like, it went right to the hour.
Yeah, I know. I'm sure we could have kept going for another hour just based on all the questions, but thank you both so much. And thank you everyone for coming, and we hope to see you at the next event.
Perfect. Thank you so much for having me.
Thank you so much. Bye everyone.